Hey everybody, welcome back to another episode of Hybrid Healing Hour. Today we are going to be discussing performance physical therapy, and we have a doctor of physical therapy with us, Ben Kelly. So I am so excited to be talking about this topic, not only to learn what the difference is between performance physical therapy versus regular traditional physical therapy, and also to kind of talk about the details and how people can better their health in general. So why don't you go ahead and start telling our audience a little bit about yourself and how you got into this field?
Absolutely. Well, first, guys, I really appreciate you having me on. It's an honor to be here. And my name is Ben Kelly. I'm a sports physical therapist, and my background is actually in strength and conditioning. I started as a personal trainer 10, 12 years ago, and then transitioned that into more team sports and like locker or weight room style strength and conditioning, transition that into more performance and rehab. And then here we are today. The physical therapy that I do with Cypher Sports Rehab and Boca is a blend of all of that. So
wow.
And a lot of people, when they think of physical therapy, they think, oh, I broke my hip, I need physical therapy for it. But there's a lot more to it.
Absolutely.
And there's a whole field of sports medicine, and that's what we're going to talk about more today.
Awesome.
Well, actually, exactly. I want you to kind of talk about what is performance physical therapy versus the traditional physical therapy that we typically send our patients for, after an injury or after surgery.
Yeah, for sure. I think that's a great question. And I think a lot of people too may have not even heard of performance physical therapy, or maybe they've thought that this is something that is only available to the pro athlete, that type of client. But I think the biggest difference between regular traditional PT and performance is the fact that performance looks to go beyond just restoring function. I mean, you guys kind of talked about, traditionally speaking, you go to physical therapy if you fall and, break a bone, or maybe you get, like a joint replacement. And the goal has always been with traditional physical therapy to restore that function and get back to walking, get back to doing stairs, being able to drive, those type of things. And I think the big difference between performance and traditional physical therapy is we look to go beyond that, right? We're taking people back to not only doing what they need to do on a daily basis, but going beyond, and if it's exercising and being active, it's that. If it's for a team sport athlete, it's performing and doing all those things that really fulfill them.
So Ben, why wouldn't traditional physical therapy do that too? That's why I feel like everybody should do that,
sure.
Right?
and I think it has the potential to,
okay.
Right? We've all kind of, at least myself, for example, I've been a product of both. I've gone to traditional physical therapy, and then I've been a patient in this more performance-based myself too. And I think one of the big key differences is the lack of a personalized approach, right? With performance physical therapy, you can look at that pro athlete treatment model and expect something similar. If you're an active adult, or maybe you're a high school athlete, it's that personalized one-on-one approach. It's I think keeping it more personal as opposed to looking at the numbers, that type of thing. More one-on-one care, and I think really just the ability to be heard. I think people now in today's healthcare landscape, they just want to be heard, and we've all been to the doctors before, where we feel like we might get a couple minutes of FaceTime with the doc, and we're in and out, and we have a million questions that weren't answered. So I think this model of physical therapy kind of addresses that.
Yeah, I mean, I've had several patients who, I say, okay, why don't we go ahead and get you set up for physical therapy? Like, say they have chronic or persistent sciatica pain, or their ankle injury or something, and they're like, I don't really want to. Last time I did that, they put me on a bike for 30 minutes, and I was in there with 5 other people. And I'm like, oh, that sounds terrible, actually. Like, what's that benefit, right? So how can somebody, can you explain that? Like, not all physical therapies, even the traditional ones, are not created equal, right?
Yeah, that's absolutely right. And I think what you just explained is what I hear also from most of my clients who come in, and most of them have tried physical therapy somewhere else, and maybe they had decent results, but it just didn't get them to where they were. And I think unfortunately, that's kind of a product of our environment right now. You look at the landscape of, insurance reimbursements, and what a lot of people don't realize is that every single year, those reimbursements are cut for physical therapists. And I'm sure on some level they're cut
and
for
us.
you guys as well. Yeah.
Everyone.
Yeah. So a lot of times what these companies do, and what you see with other companies outside of healthcare is they pass that on to the patient or the client. And they do that by, focusing on volume. If we can't make as much per patient, then we're going to see 2, 3, 4 patients at a time. And a lot of times people have realized that, but I've even talked to some people that don't even realize that that's happening. But what they report to me is like they've been, just what you said, put on a bike for 15 minutes, and then it's some hot packs, and then it's go to this machine and do these amount of repetitions, and I'll check in with you later, and that type of thing. And it's just not. It has the potential, I think, to help people. I think I would advocate that it's probably better than nothing, sitting on the sideline. But I think for most people, it's just not moving the needle and getting them to where they need to be.
Well, what I hate about that is most of my patients who are needing the physical therapy actually also don't typically work out, and therefore they don't know how to use these machines.
Yeah.
So if you're telling someone to just go on, ride the bike this way, then go over to this machine over here, and they don't typically know how to use that machine, are they being shown quality versus quantity, proper, technique?
100%.
And therefore, I've also heard of people saying, look, I was going to physical therapy for this, but then my knee starts hurting, right? Then they end up hurting themselves. And I'm like, well, were you guided? Yeah. Were you guided properly? So that's, I hate when I hear those stories.
It's unfortunate because then a lot of times it ruins people's view of physical therapy. They come back to the doc, they say PT didn't work. So, the doc a lot of times doesn't know exactly what happened. So what's the next resort? Pills, injections, surgery. And a lot of people end up going that route when there could very well be another option.
I've had patients tell me that, they've gone for like a hip replacement and they had physical therapy. Then later on they have back surgery, and they tell me the physical therapy is exactly the same. Yeah. They did the exact same thing both times, and it really should not be that way.
Yeah, that's tough to hear.
So tell me how somebody can find the right physical therapist. Is there what can they put in their Google search engine, or how do they does somebody call and get like a free consult before they start with them?
Yeah, so I think the thing that most people start out with is their search, right? When you type in, when you go to Google physical therapy near me, you're going to get 30, 40 locations in maybe like a 15-mile radius. And it can be overwhelming. But I think what I usually tell people, if they don't have somebody in mind, then look at the websites and look to see who's advertising for that one-on-one care. This is something that people who do it are very proud of it, and they're gonna advertise for it. If you don't see that right away, or at least just down on that page, then chances are it's not one-on-one care. So that'd be the first thing that I have people look into. Beyond that, you can, if you participate in an activity or a sport and you're looking for something more specialized, look into the biographies of the people, on the website. Look and see what their background is in. Do they have experience working with, people such as yourselves, that type of thing. That can show up not only on the website and the biography, but now, social media is huge. You're going to, what type of people are they working with in social media? What is their, what's kind of their line of talking when they're talking on social media? Does that align with you? And then I think too, the other thing is facility, right? Look at the facility. I can't tell you how many times I've had people in evaluations, and I'm always curious what's worked, what hasn't worked before. And a lot of these people have been to other physical therapy. They've seen progress, but they tend to plateau because they are, they're athletes. They're either playing team sports, rec sports, maybe they're working out, with classes, and their physical therapist before just didn't have the equipment or the facility to kind of take them back to that level that they needed. And so I'm talking, if your goal is to run, sprint, cut, you need room to be able to do that. If your goal is to move a barbell or dumbbells, that should be, part of your rehab too. So those are some things to kind of look for.
Right.
Does the type of therapy that you do require a lot of equipment?
It can, but it doesn't have to, right? I mean, I think a good physical therapist understands, biomechanics and how to load certain joints, and you could do that very well without weights. But I think it comes down to, specialization too. It wouldn't make any sense to, for example, I could be working with a woman who's in her 40s who likes to do, exercise classes, and I could get her, her shoulder feeling pretty good. But if we don't implement, lifts that she's going to see in those classes, such as, dumbbell lifts or, pressing or pulling, that kind of thing, then it does her a disservice. So to answer your question, yes, yes and no. So I think it's nuanced.
Yeah.
So a lot of our patients, I think there's the right fit for the right person, like you said, right? So, I mean, we do order a lot of home health physical therapy, but that is mostly for homebound patients. And that's where I think a lot, like some people come to me, they're like, oh, can't somebody just come to my house? I'm like, if you really want to succeed and you're not homebound, no, I would suggest you go out and get somebody who's going to push you. Yeah. You're limited if you're doing it in your home, unless you have a full-size gym, then, and you want that person, you really are working at that, then
absolutely.
But then you're probably not homebound either. So I would love for you to tell us some of the biggest, I guess, mistakes you might see throughout a rehabilitation process. Cause I have patients, going back to what we kind of said already is, a patient might say, oh, PT didn't work for me or something. So, and not only mistakes maybe from physical therapy side, but maybe from the patient side and also maybe our side as a provider. Like, are we not ordering the right thing?
Yeah, that's a great question. I think, to start with, let's start with the practitioner side, the mistakes that I see with, sports medicine in general and rehab. I think one of the biggest things is I guess you could consider it like a timeline-based rehab versus a criteria-based rehab. And one of the things that frustrates physical therapists is when the patient comes in with vastly different expectations than they should have. And a lot of times this comes from their referring provider saying, oh, you've had this pain for, 2 years. Why don't you go do 6 weeks of PT and you're going to be good. So I think that when we talk about timeline versus criteria, it's easy to say, oh, I did 6 weeks of physical therapy, or even as a provider say, this is going to be 6 weeks long and then you're going to be done, as opposed to, you need to meet these certain criterias to be cleared or to be done. And those criterias could be, objective and subjective. We could be doing strength testing. You look at a competitive athlete and we're testing to see someone with knee pain or say a ACL or a meniscus repair. We're testing or we're comparing side to side, right? Quad strength, hamstring strength, and we're comparing that to see the difference because we know that, too large of a percentage is going to increase the re-injury risk. Those type of things and communicating that and essentially saying, hey, when we get you to this point, when you're this strong or you're able to move through this range of motion, that's when you're going to be good to go, as opposed to, oh, it's only going to take X amount of time, because people progress, differently through those time periods. I think from a patient's perspective, a lot of the things that I see are symptom chasing, right? And what I mean by that is a lot of the people who I work with who come to work with me, they have started, with massage, with chiro, with acupuncture, with stretching, all this stuff that, I think all plays a role in rehab and recovery, but it all has one thing in common, and we're chasing the symptom as opposed to searching for and addressing the root cause of what's going on. And until that happens, until we identify that root cause, we can just expect to chase symptoms every couple of weeks, So I think those are two things that I see with, two mistakes that I'm seeing from like the practitioner side, but also the patient side as well.
Can we talk about one specific injury and kind of get your opinion on that? Like a partial rotator cuff tear. I feel like people always think, okay, well, it's torn. Do I need surgery? And I'm like, actually, no, you can go to physical therapy. You can live with a partial tear. And I explained that, but is that something you see that you feel can bring people back to like full strength again or full range of motion?
You mean the rehab or the
surgery? I guess the rehab instead of surgery with the partial.
No, absolutely. I think a lot of times too, when you're seeing somebody with shoulder pain, especially that middle-aged and older population, you can safely assume that there's probably going to be some rotator cuff tearing or fraying, however, wear and tear essentially. In fact, we don't even need imaging to tell us that. I think a lot of times MRI can do a disservice, for somebody like that. And a lot of times what we see is that, yes, absolutely, we can optimize, some postural related changes that have probably happened over the years. We can probably adjust some of the exercise routine and then really work to help stabilize that shoulder. And help with that partial tearing. I know when you hear that your rotator cuff torn, it sounds terrible and it's alarming. And at the first thought is everyone's thinking that we need surgery. But short of I tell people, short of traumatic events, falls, injuries like that result in you not being able to lift your arm, those type of things, usually surgery is the last resort for that.
And you said something that I can't emphasize enough, that imaging is not always indicated.
Yeah.
And we tell our patients, the first thing a patient says to us when they come to see us is, I need an MRI.
Sure.
Like, we haven't done anything yet. So we try to reserve imaging for the people who you think are going to need surgery. But there's so many patients that we see get better and never need anything.
100%. Exactly. Most people come in asking for it too. And I just try and, what I usually tell people to kind of calm their nerves is, with what you have going on, I'm not expecting with the tests and what we've seen now, I'm not expecting that there be any time sensitive thing where that would require surgery, within a period of time. I don't think this is going to require surgery. And I expect progress in X amount of time. If we don't see progress that I would expect in X amount of time, then maybe we'll get, a second set of eyes. We'll send you out. Maybe we'll get some imaging, that kind of thing. And I would say 90% of the people never get to that point.
Yeah.
Well, and I kind of wanted to go back a little bit because there was we were talking about, traditional, how we can, as a provider, sometimes people can write prescriptions. I always just write PT, eval, and treat. I leave it up to you guys. Go at it. But I will say there are certain guidelines that is highly pushed upon many providers and practitioners to write for the timeline of 2 to 3 times a week for 6 weeks, right? Yeah. And that's because of insurance,
yes,
right? So insurance does put a blockade on things, and that's where that guideline has come from. And even insurance will say, in order to pay for an MRI, we need to do 6 to 8 weeks of physical therapy first. And I do believe in that guideline in a sense, as you said, most people will get better before they even need the imaging. And just because your lumbar spine shows a herniated disc doesn't mean you're going to have pain, right? And you can fix that anyway, right? And a lot of times people don't understand, it's like, you can also try to rebuild or help, fixing the muscle above and below the joint to improve that joint pain.
100%. I think that's one of the things too that is going to separate that performance approach where you get a full hour with somebody, because we have the time to look above and below. And I think one of the ways that we do this is, we put them through a movement screen, and that movement screen, sure, that first visit, we're probably focused on that more on that point of pain. If it's the shoulder, we're usually looking at the thoracic spine or the upper back, and more in the area. But as we go out, we 100% want to look throughout the body and figure out areas where that person just isn't moving as well as they should. Maybe they're tight, maybe they're weak, maybe they have a hard time controlling a certain movement, with the idea that optimizing all that stuff is going to take a load off of that stress tissue that's probably giving you pain. But you can only really achieve that through a personalized approach. When you're just a number, when you're being seen for 5 or 10 minutes by somebody, like actual FaceTime 2 or 3 days a week, it's hard to really get that across.
Mm-hmm.
So let's talk about the most common injuries you see and why they happen.
Sure.
And so what do you think is the single most common thing that you see?
Right now, I'm seeing a ton of, and I think it varies by season, right? Track season is starting. Soccer is ongoing here, but a lot of ankle injuries, sprains, and a lot of hamstring and hip flexor strains or pull muscles. Excuse me. The ankles are tough because a rolled ankle or a sprained ankle is probably one of, if not the most commonly re-injured, body part. And I think we can probably all, either ourselves or point to somebody that we know who's had an ankle sprain throughout our lifetime. And I'm guilty of this myself too, growing up playing soccer and other sports. Most people, when they roll an ankle, they've been told to rest it and ice it. And then, when it feels better, go back to doing what you do. But the problem with this is that, one, we're finding out that rest and ice probably isn't the optimal thing to be doing right away anyways. But it's such a common injury. We all know people who've had it, that people are spraining their ankles. They're taking, a week off and then they're going back and they're going back to sport or activity with a partially rehabbed or a not rehabbed injury that keeps popping up. It keeps popping up. And it surprisingly takes people away from their activity or sport more than people would think, a week here, a week there, that kind of thing. So ankle sprains are super common. And I see people all the time who have chronic ankle sprains, just instability that's created from, every season, every volleyball season, every soccer season, basketball season, it's 2 or 3 ankle sprains. And that just accumulates over time. With the hamstrings and hip flexors, I think a big part of that is the ramp up. Like we go from, especially at the high school level, you might not be competing or doing that activity at that level, and then you go and it's track season, we're preseason, and people go from doing nothing to now we're sprinting, right? Mm-hmm. We're kicking a ball, max effort, and that's how this stuff happens. I think the interesting thing with the hamstrings and the hip flexors, I see as a total underobserved thing is the role that the core and trunk play in not only the prevention but the rehab of that. For a very simplistic way of looking at it, if you think the hip flexor is attached to the pelvis on the front side and the hamstrings on the back, right? That the the core's role is to basically provide stability to that pelvis. And when that pelvis isn't stable, it puts added stress on those muscles on the front and back side. So a ton of people come to me for recurring hamstring and hip flexor strains. And I always ask, and the core element is something that's almost always missed in the rehab. But beyond that, I see a lot of shoulder pain in your active adult, you're more of like your middle-aged people who are, just wanting to, crush the gym or do their exercise classes. And I think that's a lot of kind of what we touched on already, a lot of that rotator cuff, tearing, whether it's, a lot of it's probably through an impingement, you've probably heard that term. Yes. But all of that stuff, I think is a lot of it is, postural related, lifestyle factors, that kind of thing. And then really, just like the repetitive nature. And over time, I think we develop, muscle imbalances or certain ways that we move that make us more prone to that type of thing. So those are some of the common things that I'm seeing, but we see, the whole gambit, as you can imagine.
Do you recommend like warming up for, to before an exercise, because sometimes, I'm guilty of this. I will go from my house to my car to the gym, push, right? Yeah. But when I was an athlete, I always warmed up,
Yeah.
And if I'm at my house, I do a warm up, but I don't do it at the gym.
Yeah.
So it's terrible.
No, for sure. I think warming up is a really good idea. even from a performance perspective, right? Like if you go and you try and perform something without warming up, you're not even performing well, for the first 10 or 15 minutes. Right. So if you can escape an injury, then it's not even optimal to train or perform that way. But no, I think, whether if you're working out in the gym, a nice little warm up would be helpful. I talk to people who have extensive warm-ups, right. And their warm-up is as long as their workout. And I don't think it needs to be that. I don't think we need to overcomplicate things. I think, I usually tell people to just, one of two things. If we're rehabbing, in the midst of training, then we can turn our rehab exercises into a warm-up, that type of thing. Easy way to do them, and it serves both purposes. Mm-hmm. But if you're relatively pain-free, then I think it's just a matter of moving the joint or going through the movements that you're going to anticipate, and just do that in a progressive manner, right? Like increase intensity, increase the volume, and then boom, we're doing the exercise, that type of thing.
I think it's important to get the blood flowing too, a little bit, right? So I think even, and there's a difference between different stretches. So there's static stretch, versus, I forgot the name of the other one.
Like a dynamic, type stretch.
So like, do you recommend, I've always thought dynamic stretching before your activity and get your blood flowing. Like, I mean, it's a matter of like just moving your arms, like doing arm swings even.
Yeah, exactly. And if you're using arm swings as an example, that's not even necessarily a stretch anyways, right? So yeah, I mean, usually 9 times out of 10, we're doing more of like a dynamic stretch or a dynamic movement pattern that's mimicking, a pattern that you're going to get into. A perfect example of this could be, let's say you're going to do lunges in your workout, right? We could work with some, walking lunges, body weight, maybe add some upper body rotation or something like that. And it's in a sense, we're kind of stretching. We may not be taking it to that end range and holding it like you would, traditionally with a stretch. But I think that type of activity is what's going to prime you best for what you want to do.
Do you incorporate other ways of reducing inflammation, like diet and nutrition?
That's a great question. That's one of the, we could probably tie that into one of the mistakes I see a lot in rehab. Because 100%, I had a mentor a few years ago ask me this question. If you were to give somebody 3 of the best exercises known to mankind for their presentation, and they did them exactly how you prescribed them, and let's say it took 15 minutes a day, what are they doing for the other, 23 and a half hours, throughout the day? And that's something that everybody overlooks. It's something that practitioners overlook, patients overlook. And I think there's numerous reasons for it, but absolutely. What's happening outside of the gym or your sport or activity, I would argue, is probably just as, if not more important. And, we're talking about things that you just hit on. We're talking about sleep. We're talking about nutrition, hydration, stress, all that stuff, because it plays a huge role in injury and also recovery.
I want to talk about some other modalities that you have that, as you mentioned, you like to compare side by side, right? So if somebody has injury of their right quad or hamstring, then you will rehab that, but you're going to look at the like, do you have an in-body at your clinic or something similar, like a body composition analysis?
Yeah. So I don't have a body comp, machine, like an in-body. If somebody is really interested in getting that, I'll send them out. Mm-hmm. But what I use is I'm interested a lot of times in strength, because I find that the strength is a lot of times going to correlate with that body mass that you're going to find on like an in-body. So we have what's called a Tindec, and it's a load cell essentially. And what it does is it measures force output and rate of force output. So essentially what we do is we set people up depending on what muscle we're going to test. So we can use let's use the knee, someone with knee pain, and we're going to test quadriceps, right? The thigh muscle. So we can set them down. We set them in a standardized position with a standardized joint angle that we, notate each time. So every test is the same. And essentially they have a strap on their ankle, and we set them up. So basically they're going to do a knee extension. So think about going to the gym and doing like a knee extension machine. So they're in that position. The catch is that when they kick, their leg's not going to move, right? So it's essentially an isometric contraction or a hold, and that load cell is in between, and it gives feedback to the phone, an app on the phone, and it can tell us, the force that they're applying, and it can even tell us the rate of force to see if there's something going on there, and then we use that to drive our decision making. Are they ready for sport or activity, or maybe we need to tailor our approach to strength training a little bit, that type of thing.
Wow, I like that.
Yeah.
There's actually something in the book, it's a chain, but it's also called like Osteo Strong. I don't know if you've heard of it, but that's what they have, machines like that.
Okay.
Very, very
Isometrics.
much. Yeah. Like
Or
isometric
osteoporosis
strength.
stuff.
Yeah.
Oh, cool. Okay.
It's to help rebuild bone, but I like that you can measure the strength like that.
Yeah, and that's probably another thing that we could tie back to one of those first questions of what do you look for? Is like, you want to find somebody who's not guessing as to when you're ready to go.
Right. Like how they magically say you're discharged.
Exactly. Because we have a lot of tests that, you can look at in the literature that I think were once, people were doing a lot of, but we've since learned that maybe they're more subjective, and tests that include more like endurance things, like single leg squats to a certain height, or, we've got other tests that we can use, but I think on some level we need to have an objective way to test strength, because strength is going to be your biggest thing to, I think, help prevent that re-injury.
Exactly. Well, I mean, I know from looking, we do the InBody in our office, and I always am worried when I see a complete discrepancy between the left side and the right side. I'm like, that means you're at increased risk for injury. Sure. You're going to compensate or overcompensate for one side or the other, and then that can lead to like back pain and so on, right?
100%. Yeah.
If someone's having pain, do you recommend that they lay off exercise, or do you recommend that they do less exercise to not elicit pain? I mean, it's hard. Patients ask us this all the time. It's
like you
I'm
said,
having shoulder pain.
Well, as you already mentioned, like the sprained ankle, right? Yeah. And you kind of gave that as an example. So like if somebody does have that sprained ankle, you recommend still using it, but lightly?
I think, for the ankle, it definitely depends on the severity of it.
Okay.
I think there is benefit for a more severe ankle sprain to offload it, right? But we are learning that early loading in most situations for various injuries is optimal to just all out rest. So what I usually tell people is relative rest. Okay. If you're, let's say you're, a runner is the perfect example for this. Maybe they're training for let's say for a 5K, and they are experiencing knee pain, right? I think a key difference between a sports PT and a traditional PT is my job is not to shut you down. I make my living by keeping you doing what you love to do. So I say relative rest. What that could mean though is, all right, instead of going out and running 3 miles, 4 or 5 days a week, let's pull back, right? Maybe we're doing it twice a week. Maybe we're doing some other type of training that doesn't aggravate the pain, such as, cycling or, some type of circuit training. It looks different for each person, but usually I try and tell people relative rest. We need to scale back, because if we continue to just hammer the thing that's aggravated, we could do the best exercises in the world, but it's one step forward, one step back. But to kind of clarify on your original question too, because I know people are asking me if they should keep working out. I'm sure they're asking you guys. Yep. What I usually, my criteria is usually, once I have a good understanding of what's likely going on, everyone wants to know, if I keep working out, is it going to get worse? Is it going to cause more damage? So once I have a clear understanding of that, and let's say it's not, like I know that, it might hurt more, but it's probably not going to further the rotator cuff, tearing or fraying or impingement is a perfect example of that. It's probably not going to result in a complete tear, but if we keep pounding it and hammering it, it's not going to get any better. So I think one of the criteria that I use for people is if we're trying to rehab something that's already painful, we can't expect that joint or that muscle to be pain-free when we're rehabbing it. Otherwise, we're never going to give it the stimulus or that intensity that it needs to grow and become more robust. So I usually tell people, think of where you are on that pain scale. A lot of people hate to think of the pain scale of 0 to 10, right? But think of where you are. If your baseline is a 1 or a 2, is that like dull ache type pain, then I'm okay with you elevating your pain level when you exercise, maybe 1 or 2 points, okay? With the idea that is going to come back down to baseline though, no more than 24 hours, right? But preferably within 12 hours. And I tell examples of this that I use to tell people, if you work out in the afternoon after work, you shouldn't have trouble sleeping at night because of the pain that was generated. That means we did too much. And it's really it's kind of a give and take, a little bit of a test, retest, trial and error, whatever you want to call it, to find that right dosage. But I think once people can do that, it not only moves them forward on the injury front of getting stronger, but it unlocks this new mindset for them to where they're no longer viewing themselves as this broken person. And that is, I think, one of the biggest things we can get across to people in overcoming pain and injuries.
I couldn't agree more. I love that. And then do you also do like dry needling?
Yeah,
in your
absolutely.
clinic?
Yeah, we do.
You want to explain what that is?
Yeah, sure. So dry needling, the American Physical Therapy Association would classify it as using a thin monofilament needle, an acupuncture needle, to penetrate the muscle, and we're targeting intramuscular trigger points. All right. So a lot of people have probably heard the term trigger point. Without going into too much detail, think of a trigger point as a tender area in a muscle, and that muscle, for whatever reason, is just very tight, contracted. It's having a hard time relaxing. Okay. That's a super oversimplification, but we'll go with that. So the approach with trigger point dry needling is we put the needle in that trigger point and it causes a reaction through the body to just kind of relax, essentially. But that's a super, I think, it's a very, dry needling can go very much deeper than that, in a sense where there's studies now that are showing that it has so many more benefits beyond just trigger point dry needling. For example, it's known to improve vasodilation and blood flow, which is huge when you have especially a more chronic situation that we're trying to get those healing factors and metabolic, process started to kind of help your body heal on its own. It can help activate the body's natural opioid receptors and opioid production. So, we're talking natural pain relief, so people can potentially stay away from narcotics and other stuff like that. We use it with tendinopathies, right? So if you think about a tendonitis or tendinopathy, a tendon that's aggravated, whether it's Achilles, patella, or whatever, it's usually a lot of times an aggravation of where that tendon attaches to the bone, and we can go in with the needle and stimulate that connection, similar to other procedures that physicians would provide, and essentially stimulate some regenerative factors at that tendon.
So you're going into the tendon at that point, not the muscle.
So we actually go, they call it a periosteal pecking, so that we go into the bone itself and create a little bit of micro trauma there that helps drive healing factors to that connection of where the tendon and the bone is. Yeah.
So you can use it on anything. You can use it on muscle, tendon, bone.
Absolutely.
Wherever you need that source of healing.
There's a lot of people too who are using it for and have really good results with osteoarthritis too, especially in the knees. I think that's probably a combination of a lot of different factors there, everything we just talked about. But I mean, yeah, the thing I'm using it a lot right now with people with a lot of like upper trap and neck tension. And you see that a lot with, a lot of the same population who's lifting overhead. Maybe they have some shoulder pain as well. We find that the shoulder blades, the shoulder, and then the neck all of that stuff is so intimately connected. And a lot of times if those shoulder blades aren't moving optimally and maybe the back is a little bit stiff, and it's just this picture of, I'm picturing that, most people after the age of 30, really, we target the muscles around the shoulder blades and upper traps a lot to help just kind of calm them down.
That is exactly where I get all my tension.
Yeah.
That's where I store my stress, and I go for regular massages for that reason.
Yeah. So it's funny you say that, because a lot of what I usually tell people too is, the dry needling a lot of times will last longer than a massage.
Then I might just have to come see you, Ben.
Yeah. Most people.
It sounds great to me.
How often do they do it?
It depends on the practitioner. What I like to do is I like to get people in for maybe 3 or 4 sessions. And we spread that out over the course of a week, with the idea that we're not symptom chasing, right? If you can look online right now and find somebody who would dry needle you every day, every week, for the rest of your life, as long as you wanted to pay them. But my thought and approach to this is, we're going to address everything we just talked about. We're going to get some relief, and that relief is going to allow us to either move better. Maybe it frees up some range of motion, maybe it reduces some pain, allows us to train better and correct that root cause issue. Maybe we need a few follow-up treatments while we're doing that. But I tell people that if it's going to work, it's going to work in the first, few sessions, and you should know that. And don't get fooled into, this 20 pack of dry needling or acupuncture, because if that's the case, we're not actually I tell people it's like hiring a plumber to fix your sink, once a week. If it was working, he wouldn't have to come once a week, right?
Interesting.
Yeah.
Now tell me more about blood flow restriction.
Yeah. Blood flow restriction, BFR is what we can use that as an abbreviation, but that's another really cool modality that we use. And essentially think about it as we have a cuff. It's a cuff would be maybe 3-4 inches wide. We inflate the cuff.
So it's like a blood pressure cuff.
Yeah,
essentially.
Exactly. A little bit more robust,
okay.
But yes. And you put it either as far up on the arms or as far up on the thighs as you can get it. And the principle behind this is we inflate it to about 60 to 80% of blood flow occlusion, arterial occlusion. And what that does is it reduces or prevents venous outflow. It creates a environment in the tissue, in the muscle, that's lacking oxygen. Okay. And what it does is same with dry needling. There's a whole host of metabolic things that are happening, but essentially it creates an environment in a muscle that we can mimic or is a similar environment to training at a very high intensity. And where this is gold in a rehab is, think of somebody, an ACL is a perfect example. Somebody who has a knee surgery can't load the knee, but we know that we need to train this muscle at a high intensity because we know that training at a high intensity is the best way to gain strength. But if they can't tolerate it, we can put a BFR cuff on them and we can train them at much lighter loads. So we're training people at 20 to 30% of that 1 rep max. So significantly lighter loads, usually higher repetitions. There's different protocols you can use, and it gets that same effect as if we were training at much more intensity.
Wow.
So it's super helpful, people who have pain or they're unable to load.
I love it.
Yeah.
Any other gadgets or any other tips you'd want to share with us? Because I am already blown away, and I feel like this was so good.
Not off the top of my head. I think we covered a lot.
Yeah, I think so. I think anybody who's interested just needs to come see you.
Yeah, absolutely.
So how do people find you?
Yeah, so you can find me. My company is Cypher Sports Rehab. We're in Boca, and you can find that at cyphersportsrehab.com. You can learn about our process, a little bit about me, and you can hear some other patient journeys and that kind of thing. And then I'm also on Instagram primarily at Cypher Sports Rehab as well.
Perfect. And I'll attach all that to the show notes.
Yeah, perfect.
Thank you.
Guys. Yeah, thanks so much.
Thanks for coming on today.
Absolutely.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.